Please start.
A very good evening to all. Myself, Dr. Sonali Shirbhate, Chairperson Women's Committee, Maha-AP. I welcome you all. This program is brought to you by Maharashtra IP as along with Women's Committee Maha-AP. As you all know, we are taking all zones of speakers from all zones of Maharashtra. And today also we had taken efforts for this, and we had came up with the topic of ORS week celebrations, especially ORS and gastroenteritis is the theme for this session. So we all will be brushing up our knowledge about the gastroenteritis and the rehydration therapy. So with this word, I welcome our President, Dr. Ramakant Patil sir, Secretary, Dr. Amol Pawar sir, our MMC observer, our expert, Dr. Mandar Deshpande sir, Dr. Mahesh Kore sir, and our speakers, Dr. Nilesh Shinde, Dr. Sandeep Gaikwad, Dr. Harshal Wagh, Dr. Madhur Karwa, and Dr. Nitin Rao. As well as I acknowledge the presence of respected Central IP dignitaries, Renu Boralkar Madam, as well as other respected dignitaries present in this session. Sorry if I couldn't take the name of all. But most important, I am most thankful to all the Women's Committee EBs, Dr. Neha Singh, Dr. Manju Sherkar, Dr. Mangai Sinha, Dr. Grivita Raikar, Dr. Sonal Shinde, Dr. Pallavi Patil, Dr. Manjusha Giri, Dr. Swati Patil, Dr. Sucheta Pofre, Dr. Dipti Deshmukh, Dr. Shilpa Dudgavkar, and Dr. Nivedita Patil. All have taken a great efforts for this session. So I welcome our women EB for this session also. So moving further towards this session, first of all, I would request our president for his presidential address. Over to you, Dr. Ramakant Patil, sir.
Thank you, Sonali. The wonderful efforts of our Maha-IP Women's Wing and excellent Tuesday tech sessions every month. And this time already 100 delegates are over in first 2 minutes. And it is not for your credit hours. It is for the topic chosen by this Women's Wing. It is acute gastroenteritis. And friends, we need to change whatever we have learned in 10-15 years either becomes obsolete or 50% becomes has changed for good. And friends, we should know, many of us are probably not knowing how to give, how much dose of ORS is to be given for correcting rehydration, what different home-based ORS, and still many of us are prescribing 0.2 DNS or ISOP. It has to be thrown into Arabian Sea. It has not to be used at all. And so many things will be elucidated. We have got experts, Dr. Mahesh Kore and Dr. Mandar. They will definitely elucidate and help and give their expert comments. Whatever today's galaxy of speakers are going to present this topic. And it is definitely, we are all ears and eager to hear from them. One more heartening and gratifying thing is that every Tuesday Tech, every subspecialty connect, all the speakers are from different corners of Maharashtra. We have got Nilesh from Ratnagiri, Sandeep from Ahmednagar, Madhur Madam from Jalna, Nitin from Amravati, and Harshal from Sangli. So what a wonderful representation across, and experts from Nipani, Kolhapur, and Aurangabad. So we are all the this thing promotions of periphery people also, including experts and academicians. There is no dearth of academician across Maharashtra, and it is really heartening, gratifying, and it is really a very heartening situation that my colleague and seniors like Praful Patel, Atul Dashputre, and so many senior people are there and who have logged in from 9 p.m. to start with. My EB colleagues, Dr. Renu Boralkar, and other EB colleagues from CIAP, they are there, all Maha-IAP EB colleagues. So I welcome you all experts, today's MMC observer, and all the galaxy of speakers. And we are all ears to hear pearls of wisdom and what has changed for good from you all. Best of luck to everybody, and thank you for giving me an opportunity to express my thoughts. Back to Sonali.
Thank you, sir. Thank you for your kind words. Now I would request our Secretary General, Dr. Amol Pawar, sir, for his secretary words.
Thank you, Sonali madam. First of all, welcome Dr. Sachin Gaikwad, who is MMC observer, who is attached to this Maharashtra University of Health Sciences. And then also today's expert, Dr. Mahesh Kore sir from Nipani and Dr. Mandar Deshpande sir from Chhatrapati Sambhajinagar. I welcome all the speakers from different corners of Maharashtra. Next week we are celebrating ORS Day and ORS week from 25th to 31st July. I appeal every every office bearer of different branches across Maharashtra to celebrate this ORS week and ORS Day also in community as well as in medical colleges and this your own clinic also. Over to you, Sonali ma'am, for further proceeding. Thank you.
Thank you, sir. Thank you very much. Before moving on to session, let us know.
तुम्ही म्यूट झालाय.
Sonali, unmute कर.
Before moving further to the session, unmute केलंय, sir.
हो, audible आहात.
Yes, thank you, sir. Before moving further, let us know something more about our experts, our judges for this session. We are fortunate that we got Dr. Mandar Deshpande sir and Dr. Mahesh Kore sir as an experts for today's session. About Dr. Mandar Deshpande sir, he is the director and consultant pediatric intensivist at Amrut Children Hospital, Aurangabad. His area of interest is fellowship in critical care. He is national faculty trainer for NRP, ALS, JAM and HOPE module of IAP. He is IAP West Zone coordinator for BLS and NRP. He was AB Maharashtra State Pediatric Intensive Chapter, and he is author for PALS Manual and also publication for the international journals. Then about our second expert, Dr. Mahesh Kore sir. Welcome, Dr. Mandar Deshpande sir. I would like to welcome Dr. Mahesh Kore sir. He is a senior pediatrician and clinician, Nipani, Belgavi. His area of interest are rheumatology and brucellosis. He has various publications. He has been awarded for paper presentation on IEM in 2006. He is the winner of 10th State IDCon Karnataka 2021. Welcome, Dr. Kore sir. So moving further, over to you, Dr. Grivita, for our speakers' CVs and their presentations. Dr. Grivita.
Thank you so much, Sonali ma'am. Thank you so much, Sonali ma'am. Moving on next, we have Dr. Nilesh Shinde. The topic is home-based rehydration and other management. Sir is a secretary IIP Ratnagiri, practicing at Dhanvantri Hospital, Ratnagiri. Over to you, sir.
Yeah, thank you. Good evening, everybody. And thank you, IIP Women's Wing, for giving me this opportunity. I will start sharing my slides. One sec, I'm sharing this. One second.
Are you not able to share, sir?
Yeah. No, I am opening this. Can you hear my slides?
No. Please click on share screen button first.
Hi.
सर शेअर स्क्रीन बटन वर तुम्ही क्लिक केलं ना की तुम्हाला विंडो दिसतील.
Yeah.
प्रेझेंटेशनची विंडो तुम्ही सिलेक्ट करा.
Yes, yes, yes. 1 second. तेच आहे. हा, एक आहे, हा. ते open कर. Exit, हा. Share. Yeah, हा. तेच.
Yes, yes,
Yeah.
yes. Make it a full screen, sir.
Yeah.
Slideshow.
Slideshow.
Yeah.
Sir,
Ma'am?
make it a full screen.
Yeah, I've made the
Yes. Yes, yes, yes. Visible. Yes.
My first topic is acute gastroenteritis, home-based rehydration and other management. So first is definition. Acute gastroenteritis is the inflammation of stomach, small intestine or large intestine, leading to a combination of abdominal pain, cramping, nausea, vomiting, and diarrhea. First, you have to assess the degree of dehydration before giving the homemade remedies. There are 3 stages of dehydration: mild, moderate, and severe. You have to look for general appearance, eyes, thirst, and skin turgor, and assess the signs of dehydration, some dehydration, and severe dehydration. Home rehydration remedies can be given to the patients of mild and moderate dehydration only, and assess the status of hydration every time. If the case is going in severe dehydration, the patient must be admitted at the hospital. So in mild dehydration, there is a minimum dehydration. Percentage of body weight loss is less than 5. Estimated fluid deficit is 50 ml per kg. Goals of management is replacement of ongoing losses of fluid and electrolyte. Fluid therapy is maintenance, that is oral. Treatment facility should be at home. Rehydration fluid is ORS. And amount of rehydrating fluid is ORS for every loose stool. You have to give 10 ml per kg for every stool. Then plan B, there is a state of dehydration. Percentage of body weight loss is 5 to 10%. Fluid is 50 to 100 ml per kg. Goals of management is correction of existing deficits of fluid and electrolytes. Fluid therapy is oral. Treatment facility is health facility and at home. Rehydration fluid is ORS. Amount of rehydrating fluid is 75 ml per kg over 4 hours. Plus non-breastfed infants less than 6 months, you have to go 100 to 200 ml of clean drinking water. Older children and adults, free access to plain water in addition to ORS. Monitor every hour and reassess after 4 hours. If still in plan B, repeat as above. And if it's rehydrated, shift to plan A. So ORS, this is an age-old home remedy for treating loose motions. A packet of ORS can be either procured from the chemist or you can prepare the solution at home. The efficiency of ORS is based on the ability of the glucose to stimulate sodium and fluid absorption in the small intestine via cyclic AMP independent process. In its simplest and original form, ORS was an isoosmolar glucose electrolyte solution with added base, for example, citrate in WHO ORS, that were designed to correct dehydration and metabolic acidosis. But nowadays, the hypoosmolar solution is used. This is the difference between standard ORS and low osmolarity ORS. In standard ORS, trisodium citrate dehydrate is 2.9 gram. In low osmolarity is 2.9 gram. Sodium chloride is 3.5 gram in standard ORS. And in low osmolarity ORS, it is 2.6 gram. Potassium chloride is 1.5 gram. And same in low osmolarity ORS. Glucose is 20 gram. And in low osmolarity ORS, 13.5 gram. So in standard ORS, osmolarity is 311 milliosmol per liter, while in low osmolarity ORS, it is 245 milliosmol per liter. So what is the advantage of low osmolarity ORS? There has been a concern that the original solution, which is slightly hyperosmolar when compared with plasma, may risk hypernatremia, that is high plasma sodium concentration, or an increase in stool output, especially in infants and young children. So in pediatrics, the low osmolarity solution is used. Other than how you can prepare it ORS at home, So boil 1 liter of filter water and allow it to cool. Add 6 teaspoons of sugar and half a teaspoon of salt to the water and mix it till it dissolves completely. Give the ORS to the baby at regular intervals to keep dehydration at bay and to make up for the loss of salts and fluids. If you are unable to make the solution at home, purchase a packet from a chemist. Other than this ORS, rice water is also a great way of replenishing lost fluids and salts. Another is coconut water. Is a wonderful liquid to aid your child's recovery from a bout of diarrhea. Not only does it taste good, but it also helps the body regain lost fluids. It is recommended to give coconut water to your child at least 2 to 3 times a day. Then another is buttermilk. Homemade buttermilk is effective when it's come to fighting germs and bacteria. It soothes the digestive system quickly and it is tasty too. Add salt to it and let you baby drink it. It is recommended for kids who are about 8 months. Lemonade. Lemon is found in most households and is a great home remedy for curing loose motions in kids. It is full of anti-inflammatory and antibacterial properties, which makes it a reliable and easily available remedy. Add 4 to 5 tablespoons of lemon juice in 200 ml of water. Add sugar and salt for taste. Your baby's upset stomach will be relieved and the pH balance is then you can give rice kanji, bread, that is banana, rice, apple, and toast, and other things which can be given like mint, nutmeg, carrot juice, smashed potato, puff rice, breastfeeding, etc. So these are the home remedies. Other management includes fever. You can give antipyretics like paracetamol, ibuprofen, vomiting, antiemetic, domperidone, or ondansetron, distended abdomen, antiflatulent drugs, colic pain. You can give antispasmodic like dicyclomine. Then zinc, it helps in reducing the duration, severity, and prevents further repeats of diarrhea for next 3 months. Those 6 months to 5 years of age, 20 milligram per day for 14 days, and 2 to 6 months, 10 milligram per day for 14 days. You can protect your child's bottom, changing your child's diaper often, washing your child's bottom with soap and water, pat it dry or let it dry in the air, baby wipes, using a barrier cream on your child's bottom. You can do the prevention by keeping your child at home until the vomiting and diarrhea stops, washing your hands, using the toilet and before making and eating food, not sharing toothbrushes, drinking cups, and utensils such as forks, knives, spoons, and chopsticks. If your child puts toys in his or her mouth, do not let him or her share toys. So this is the home remedies which can be given and for the mild and moderate dehydration, so that the admissions in the hospital can be prevented. Thank you.
Dr. Mandar would, our
Yes.
expert Dr. Mandar would like to comment.
Yes, thank you, Nilesh. It was an excellent presentation on home-based remedies for prevention and treatment of diarrhea. Here, one message should be loud and clear that you can't use juices. No juices, no apple juice, no other juice, because juices have a lot of sugar. Even Glucon-D or glucose, plain glucose will not help the child. That is one thing. Second important thing is that ORS ready to use is not the solution. ORS that is in sachet is the solution to be given. And nowadays we only have what you call as a low osmolality ORS. So whatever it is, there is a low osmolality ORS. Yeah. And ORS has two effects. One, it will be helpful in preventing dehydration also. So when there is a plan A where there is no dehydration or a mild dehydration, ORS has to be used, and ongoing in plan B, if the child deteriorates, you need to increase the volume of ORS to be given. And ideally, I don't encourage using home-based ORS. Initially, in our textbooks, there was a topic of home-based ORS, and every expert used to talk about home-based ORS. But there are n number of errors when we prepare homemade ORS. So it should not be done unless you are a desperate person and you are not having access to ORS. Normal ORS sachet we all have. They're economical. They're very feasible, very cheap. Government supplies are free of cost. We should encourage more and more ORS. And out of all these things, the best homemade ORS, I think, should be coconut water, if at all you want to give. Second is rice feeds, you said. So rice feeds should be told to them like it should be salted rice feeds, because most of the people give rice without any salt. And initially we used to say that 1 glass of water, 2 teaspoons of sugar, 1 pinch of salt. Now pinch of salt, mother pinch of salt and तुझं pinch of salt. So there can be a lot of errors. So it is better we avoid. If at all you have desperate measures, you don't have access to ORS, better to give coconut water, or for that matter, standardized ORS that you discussed. So that is all about. And we are at a stage where under 5 mortality is very high. And we all know that the gastroenteritis is the third most major cause of under 5 mortality, apart from prematurity and respiratory infections. So we need to be very aware, and we need to educate and teach parents about the use of ORS and basically hygiene of the ORS and how it works. It works wonderfully. And I think we should all stick to the standard ORS rather than doing all types of these jugards. Okay. So that is the message, loud and clear. Thank you. It was a great talk.
I just wanted to add 1 or 2 things.
Yes, sir.
Here, there is definite reason and concentration why we are shifted from standard to WHO ORS.
Absolutely. Yes.
So, and sodium will get transmitted only with glucose, definite proportional, that Dr. Dilip Mahalanobis, who has invented this ORS in 1971 in 17th of October. So we'll be doing injustice to him and by giving home-based ORS, because
Absolutely.
we don't know the exact preparation.
Absolutely.
Second, 2 things I wanted to no audience should go with the concept of using anti-flatulent drugs. It should not be in the treatment. Nobody should go with the concept of giving dicyclomine. It should not be Nilesh. It should not be included in our presentation. So no dicyclomine, no anti-flatulent drugs. So sorry, but it should not come in any academic presentation.
Okay.
Otherwise, excellent presentation and very good take-home message. Thank you. Thank you to interrupt in between. But I thought at the end it will not be correct. Here only we should invent.
Absolutely, sir.
And should tell that. No dice.
Absolutely, sir. Absolutely.
Yeah, I agree with you, sir.
Yeah.
It's very important.
Yes,
You have given
yes.
this message. Thank you.
Yes.
Thank you.
Thank you so
Yes.
much, sir, for the crisp messages. Moving on next, it's Dr. Sandeep Gaikwad from IIT Ahmednagar. Sir is working at Sankalp Children's Hospital. The topic is correcting dehydration by IV fluids in acute gastroenteritis. Over to you, sir. Dr. Sandeep Gaikwad.
Yes. So are my slides visible?
Yes, you are
Yes, sir. It's
audible and
visible.
slides are
Yes,
beautifully
go ahead.
made. Just make it full screen.
Yes, sir, it's full screen. It's full
Yes.
screen. Please go ahead.
So good evening all, my seniors, teachers and my colleagues, and thank you IIP and Women's Wing to give me an opportunity to talk on this small topic. My topic is correction of dehydration by IV fluids in acute gastroenteritis. That means it's in severe dehydration. As we all know, acute gastroenteritis, it looks very simple, but it can be really fatal, which can lead to severe dehydration and even hypovolemic shock and major electrolyte imbalances, which leads to renal insufficiency, seizures and all. And the dehydration can be so severe because of increased loss of water and electrolytes, and that can lead to severe hypovolemic shock. And it could be worldwide second leading cause of death because of gastroenteritis and dehydration. And we all know that small children are more susceptible because of these particular features. So what are the indications of giving fluids, IV fluids in gastroenteritis? Which kids do we need to give? The child with severe dehydration, with or without hypovolemic shock or impending shock. The child who is already on oral rehydration therapy for moderate dehydration, and that therapy is not improving child's hydration. So such cases can be considered for IV fluid therapy. Third indication is child with persistent vomiting. In spite of giving oral child is still vomiting and his dehydration is getting corrected, or any dehydrated child with following red flag signs like child is very unwell or deteriorating child, child with altered or decreased level of consciousness, child with deep sunken eyes, tachycardia, tachypnea and reduced skin turgor. Then another indication which is very important, the child with severe abdominal distension because of ileus or intussusception, that child needs an intravenous fluid therapy. Child with very high stool output, more than 10 ml per kg per hour, very purging diarrhea. Then these are two indication non-reliable parents for giving ORT in mild to moderate dehydration, because we can't rely on the parents as they are illiterate, and such children can be admitted and given IV fluids to prevent further progression. Or any child who is residing far away from the healthcare facility for follow-up, and we can't guarantee their follow-up, and that child can deteriorate. So these are the indications of giving IV fluids. So successful and effective management, does it matter? Yes, it does matter in management of dehydration, but it has few aspects. That aspects are proper and careful assessment of degree of dehydration. Then second aspect is rapid expansion of intravascular volume if necessary. The third aspect is correction of total fluid deficit. Fourth is provision of maintenance fluids and electrolytes. Fifth is replacement of ongoing losses through ongoing diarrhea and vomiting. And last and but not the least is monitoring, clinical monitoring of the dehydrated patient and lab parameters like electrolytes. So that kind of monitoring is important. So once you do all these 5-6 steps, we will be able to successfully manage the child with severe dehydration. So what are the goals? Basically to decide starting point of treatment, to determine which patients can be safely sent home for therapy, or which patients can remain for observation during therapy, or which patient should immediately receive more intensive therapy like the patients who are in shock. So rapidly we can assess initially severe dehydration by asking how long the diarrhea is going and is there any blood in the stool, or we can look at the child's general condition quickly, whether child is lethargic, unconscious, restless or irritable. We look at the deeply sunken eyes and we offer the child fluid if he is able to drink or not. We pinch the skin and see whether it is delayed. And then we come to the conclusion that look, this child is severely dehydrated, and we find that the child is apathetic, very lethargic or unconsciousness. He drinks poorly or is unable to drink. Child is tachycardic with bradycardia in most severe cases. If you feel the pulse, which will be very weak, 3D and impalpable, his breathing will be deep acidotic, and his eyes will be deeply sunken, very dry, the tears will be absent, mouth and tongue will be dry, parched, skinful pinch, recoil will be very delayed or very slow, more than 2 seconds, capillary fill at the tip of fingers will be prolonged more than 2 seconds. If you feel the extremities of this child will be cold, motile or occasionally cyanotic, and if you ask mother about urine output, she will say that she hasn't passed, baby hasn't passed urine for a long time. So WHO has defined severe dehydration with these 4 points: child's condition, lethargic unconsciousness, eyes, and child's ability to drink, and the skin pinch. If 2 or more of these signs are there, then the WHO defines or says that it is a severe dehydration, it is an emergency. If we know the way, we weigh the patient and use treatment plan C as per the WBC and start treatment very urgently. And this is the diagrammatic picture of child with severe dehydration. So what are the phases of fluid therapy? We'll see in brief, like the principles. The first phase is resuscitative phase. Here aim is to restore our adequate tissue perfusion and prevent end organ injury. That is very important phase in the management. The next phase is a titration phase, where IV fluids are transitioned from boluses to maintenance, and we determine how much intravascular repletion is achieved by giving fluids, and we keep audit of fluid gains versus losses in children in this phase. Third phase is maintenance phase, where fluids are given to achieve precise homeostatic balance between needs and losses. And last phase is convalescent phase of fluid therapy, where exogenous fluids are stopped and patient returns to intrinsic fluid regulation. So we should know these kinds of phases. And then acute rehydration approach. The child with dehydration, severe dehydration, how do we approach? We initially manage hypovolemic shock, then rapid rehydration, which is WHO Plan C, which is now widely accepted. Then there is one more concept of slow rehydration, slower than the WHO plan, and traditionally what we were taught initially, correction over 24 hours. So first, if child with severe dehydration present with signs of shock, secure immediate intravenous access, and if it is not possible, secure intraosseous access. We send bloods, important bloods like electrolytes, renal functions, possible ABG, VBG or CBC. And then we start this child 100% oxygen. First and foremost thing is giving IV fluid bolus, 20 ml per kilo. WHO recommends ringer lactate, but normal saline can be used. 20 ml per kg of bolus can be given over 10 to 15 minutes. Such 3 boluses of 20 ml per kg can be given in 1 hour. But after every bolus, we need to assess pulse rate and volume. We need to assess capillary refill, child's mental status, whether it is improving, and core periphery temperature difference. If at any stage of giving these boluses, if signs you feel that they are improving, then we start stopping that aggressive resuscitation, further boluses, in order to avoid fluid overload. But after 3 boluses of 20 ml per kg, and you see that there are no such great improvement in the signs of dehydration, then one need to suspect that child may have septic shock because of some other associated morbid condition or associated other condition. Then we may think of giving inotropic support, and maybe we need to involve pediatric intensivist in such cases. So why ringer lactate? WHO says that because it has lactate, and that lactate gets converted into bicarbonate in vitro and in vivo, and that helps to combat metabolic acidosis, which is there in hypovolemic shock. And in normal saline, on the contrary, has high chlorides, which sometimes can induce renal injury. That's why WHO prefers ringer lactate. And there is one study in Indian pediatrics, ringer lactate versus normal saline in acute diarrhea and severe dehydration in year 2012, which concluded that there was no difference in improvement in pH over baseline between RL and NS group. But in RL group specifically, there was a short duration and less fluid requirement for correction of dehydration, less ORS required after correction phase, and there was a shortened median hospital stay by using ringer lactate. That's why we prefer ringer lactate. I would just involve Frank Starling principle here. When we have child with severe dehydration with hypovolemic shock, child has very low preload and stroke volume is also low. So if we start giving first and second bolus, we are here at the steepest curve of this curve, and there is vigorous fluid response to fluid bolus. But as we go further on plateau phase, and if we are still giving maybe second or third or fourth bolus, then there is very feeble response, because once preload approaches this flat plateau of the Frank Starling curve, further fluid boluses will do nothing to improve the stroke volume, and we might land up into fluid overload. So what I would recommend that we should all doing is, every bolus we should reassess the hemodynamics or perfusion, avoid unnecessary fluids or unnecessary boluses to avoid overload. So that we can think of using Frank Starling curve here. So second are usually followed WHO Plan C. What WHO says is, when patient with severe dehydration and shock, start IV fluids immediately. WHO also recommends that the patient can drink little bit of ORS, give by mouth until you are setting up the IV drip. And WHO recommends to give 100 ml per kg of ringer lactate as per the age in 2-step approach. If child is less than 1 year old, first step is give 30 ml per kilo in first hour, then reassess and then give 70 ml per kg in next 5 hours, and then again reassessed. For older children more than 1 year, first step is give first 30 ml per kg in 30 minutes, little bit faster in older children, and then reassess again. And second step is give 70 ml per kg in next 2.5 hours, that is in short time. So every time we have to reassess child after every bolus if hydration is improving. If it is not improving, the drip rate is made more rapidly. And we monitor the progress of intravenous rehydration every 15 to 30 minutes until strong radial pulse is present. Thereafter, we reassess every hour for improvement in dehydration. What we reassess is, we see heart rate trend, we see type of respiration, mean blood pressure, alertness of child improving, pulse volume improving, core periphery temperature difference improving, child is passing urine maybe, capillary refill, skin turgor, and then simultaneously we keep offering child ORS if he is awake now, and drink and see the response. So at the end of 3 to 6 hours of our rapid rehydration as per WHO protocol, if signs of severe dehydration are still present, WHO says that continue rehydration as per plan C again, one more set. If child, second scenario will be if child is improving, but there are some signs of dehydration, child is able to drink now, then discontinue iron infusion, that's what WHO says, and give ORS solution as per plan B, that's what sir has said earlier. If there are no signs of dehydration after 6 hours, we follow plan A, keep child in hospital at least 6 hours before discharge, ask and educate mother to give ORS solution, continue ORS solution till diarrhea stops, and most importantly teach mother about danger signs and when to bring child back again if there is again vomiting, dehydration. And there is one more study like gastro study in phase 2 rehydration trial for severe dehydration. In this study there was a comparison of WHO plan C, which is rapid rehydration over 3 to 6 hours as per age, versus slow rehydration. Why this study had come? Because in Africa, in FISH trial and in some Kenyan hospitals and some 3 big systematic reviews, they were using WHO protocol rapid rehydration, and there were reports of mortality because of fluid overload, and that's the reason this gastro trial had come. What they have done is they have given 100 ml per kilo of ringer lactate over 8 hours without boluses, and they have showed that as compared to WHO protocol, their slower rehydration is also safe, and no difference in correction of hydration and time to tolerate oral fluids and time to discharge was similar in both WHO rapid rehydration group and slower rehydration group. But mortality was substantially lower with was little bit higher in rapid rehydration group, and that was a report from Kenya hospital, around 1211 children studied. And this was what that slow arm, no shock or with shock, plan was to give 100 ml per kg over 8 hours, as WHO plan C was dividing into 3 hours and 6 hours. So, and what we have taught, like last traditional dehydration was, we calculate 24 hours fluid as per the need, fluid deficit, maintenance requirement and concurrent losses, and we then sum up it. So how will you calculate fluid deficit? The formula to calculate fluid deficit is percentage of weight loss because of dehydration into 10 into weight, and that is the answer is fluid deficit. And then we calculate maintenance fluid by Holiday-Segar formula, less than 10 kg 4 ml per kg per hour, 10 to 20 kg 40 ml plus 2 ml per kg for first every kg for more than 10 kg, and for more than 20 kg 60 ml plus 1 ml per kg for every kg more than 20. So that way we calculate maintenance, so deficit plus maintenance, and then we go for ongoing losses. Per stool, WHO recommends 10 ml per kg per stool of fluid to be replaced, volume to volume, and for vomiting 2 ml per kg of per vomiters fluid should be replaced volume to volume. So there are different approaches: combined deficit plus maintenance approach, or sequential deficit plus maintenance approach, or popular approach. What we have been taught earlier is calculate for 24 hours, half of fluid is given in first 8 hours and remaining half is given in 16 hours. but there are two these approaches: deficit maintenance, sequential approach.
So we're exceeding the time.
Just 2 or 3 slides. So we'll take a hypothetical case briefly. When you're a child with history of vomiting and diarrhea, all signs of severe dehydration, child is weighing 8 kg, sodium is 138, potassium is 1.8. So deficit comes because the child is 15% dehydration into weight into 10, so it's around 1200 ml. Daily maintenance as per holiday cigars is 800 ml. So total requirement in 24 hours is 2 liters. So rapid intravenous bolus here we have given 20 ml per kg. So remaining deficit is 1200 minus 160 is around 1 liter. And then ongoing losses we calculate. Choice of fluid for both deficit and maintenance is isotonic saline, 0.9% NS with 5% dextrose, and we add potassium when child start report is there, potassium report, or child pass urine. And I would like to add this slide for maintenance fluid. As sir said that now 0.2 DNS is not used, and this is the clinical practice guideline in American Academy of Pediatrics, appeared recently in 2018. The American Academy of Pediatrics recommend that patient from age group 28 days to 18 years of age requiring maintenance IV fluid should receive isotonic solutions with appropriate potassium chloride and dextrose, because they significantly decrease the risk of developing hyponatremia. So nowadays we should start using this maintenance fluid if we are not using. So key messages in my talk will be: we should assess rapidly dehydration. Shock with dehydration should be treated by fluid bolus, ringer lactate if not available with NS. Follow WHO Plan C for rapid rehydration in severe dehydrated child. Monitoring of child on rapid rehydration is very essential to avoid fluid overload. Investigation of electrolytes and renal parameters important so as to correct electrolyte imbalances. Resuscitation fluid in dehydration sick child is ringer lactate or NS. Maintenance fluid 0.9 DNS. Maintenance for perioperative is isotonic. Isotonic is not harmful and is not associated with hypernatremia. 0.45 DNS can be used for non-sick child. If child is on IV fluid, serum electrolytes are done at least daily, and now 0.2 DNS is no longer used in infants and children. Thank you. Stay hydrated.
Over to you, Mandar sir, for your expert comments. Dr. Mandar.
Don't follow WHO protocol blindly. WHO has not given truth in at many occasions. We know about COVID also. So if you follow WHO protocol, you will land into giving too much of fluid. Always. Am I audible?
Yes, sir.
Yeah. Always titrate clinically. A good urine output, maybe a 0.5 ml per kg per hour of urine output, palpable pulses, warm extremities, falling heart rate, improvement in mentation. All these clinical scenarios of managing dehydration or shock will come into scene. And the most important thing, as you mentioned, choice of fluid should be normal saline or ringer lactate. Given a choice, I will use ringer lactate, but normal saline is still not harmful because we give not that much of fluids to to have a hyperchloremia. And hyperchloremic metabolic acidosis is a problem when it is used in higher concentrations, higher volume, especially in adults or in burns. So you can use normal saline also. And you, as correctly mentioned, don't use isolate P. P stands for poison in pediatrics. Don't use P. And as Dr. Ramakant Patil sir mentioned it earlier, throw it in Arabian Sea. I think we should all ban this isolate P as we banned Nimesulide. So similarly, we should ban isolate P. We should not use it. And a very good take-home messages, but I would like to again tell that don't blindly follow WHO protocol, because otherwise you are going to overload the child more often, because we all, as a clinician, overestimates the grade of dehydration. Thank you.
Sandeep sir, may you please stop sharing your screen?
Yes.
Mandar, may I have one or two suggestions here? Hello?
Sir, bola na sir.
Yes, sir.
Yes. For maintenance, it is okay to add dextrose, but for rehydration, we shouldn't be combining NS with dextrose. That is one thing. Secondly, for initial resuscitation, NS will be always preferred over ringer, even if Mandar has said that he will, given a choice, he will have RL, but that will be for subsequent dosages where we don't want to have hyperchloremic acidosis or hyperchloremia. But given for the cost, allergic reactions, availability, and no inferiority over each other. So initial normal saline will be still useful in initial rehydration, and dextrose should not be used. And as you have very wonderful slides, and that plan C of WHO, as Mandar has clearly said, if there is more mortality with plan C, what is a great hurry in rehydrating in a very fast manner?
Absolutely. It has to be
Yes.
slow rehydration, definitely.
Yes.
And they have put up guidelines because this choice of fluids have differed in various guidelines. WHO has said it is ringer lactate. Kerala government has said it is ringer lactate. NICE has suggested 0.9 DNS along with that. And ESPGHAN has suggested use normal saline. So there is a lot of
But
debate
all
here.
intensivists are suggesting not to use dextrose in initial
Absolutely,
rehydration.
sir. Absolutely, sir. And
It
dextrose
is
should be
only in
used.
maintenance the dextrose
Absolutely.
has to be added.
Absolutely. Dextrose
Unless
has to
until
be used.
you have shown that patient has got hypoglycemia.
Yes. Dextrose has to be treated separately. Hypoglycemia has to be treated separately. And management of shock and rehydration should be normal saline or ringer lactate. And if it is possible, plasma light is the best solution to have. But plasma light we don't have, and many times because of the affordability, it is a real balanced solution rather than this what you can say false ringer lactate as a balanced solution. Thank you, sir.
Thank you, experts. Thank you so much. Moving on next, Dr. Madhur Karwa. Madam Sana MBBS from BMGMC Yavatmal and DCH from BMGMC Solapur. Madam is from IIT Jalna. The topic being management of hypo and hypernatremia and hypo and hyperkalemia. Over to you, Dr. Madhur.
Yes, thank you, ma'am. Good evening, everyone. Tonight, I'm gonna run quickly through my topic. I promise I won't bore you guys much. Firstly, I want to thank Dr. Gritika and Dr. Sonali for their valuable inputs at the time of mock presentation. I sincerely thank Dr. Mandar for his insights. Those have helped me to reconcile my presentation. Umesh, the only thing which shall help is group discussion. So let us try it together. So the next slide नहीं हो रही.
Pallavi madam, guide kara.
Just a second. I am not able to.
You have to close this again. You have to
Yes,
close
I
this.
have to.
Second slide now.
अरे, छोटू. Stop कर इसमें. अब इस रंग में. 2 मिनट. Slide share. नहीं, अरे वो slide. अपना.
Yes, yes, yes. Slideshow.
Yes, sidebar. From beginning, then I'll just change it. Thank you. I think it has hanged. नहीं हो रहा ना, it can be next page आ रहा.
Should I ask the next speaker to?
Got it. Can I continue?
Yes, ma'am.
Thank you.
Yes, please, yes.
Yes, sorry for the inconvenience. This is a very perplexing topic. So the only thing which can help is group discussion. I would love insights from Dr. Mandar sir and Dr. Kore sir. So let's try it together. I know physiology is beyond the scope of my lecture today, but if we want to, sorry?
Screen isn't visible.
Your screen is visible and you are loud and clear.
Okay.
Please neglect
Please continue.
intermittent voices. Sometimes somebody is not mute. Please go ahead.
Okay. So physiology is beyond the scope of today's lecture, but if we really want to treat and diagnose these children and treat them well, I'll just go through physiology in 30 seconds. Potassium is a major intracellular cation and mostly responsible for excitability of nerves and muscles. It is majorly intracellular, and there are some factors which will affect movement of potassium into the cell, and those are insulin, epinephrine, alkalosis, beta-adrenergic agonists. And there are some factors which will push potassium outside the cell into the ECF. So they are exercise, cellular lysis for any reason, hyperosmolality, acidosis, and alpha agonists. Potassium is ingested and excreted in kidney, especially in distal convoluted tubule and collecting duct by aldosterone. As the picture itself depicts, potassium imbalance directly affects heart and so is a medical emergency which has to be managed aggressively. Before managing aggressively, we should have in mind spurious lab reports which are common because of difficulty in sampling. And so a second report is needed. If serum potassium is more than 6.5, get an ECG. Peaking of T waves is the first sign, but remember normal EEG, even with normal EEG, we can have fatal arrhythmias. Symptoms, actually, cardiac toxicity usually precedes clinical symptoms. So this emphasizes that absence of symptoms doesn't imply absence of danger. Getting on to management, there are two primary goals. Firstly, stabilize the myocardium, then simultaneously reduce potassium load from the body, either by increasing its excretion or shifting potassium into the cell. This is where physiology shall help us. Treatment, oral potassium is great. Every one of us has used K-Sol. It has to be given in the doses of 1 to 2 milliequivalent per kg per day, maximum 60. IV potassium has to be given with precision, but it is fast acting. It has to be given in the dose of 0.5 to 1 milliequivalent per liter. First goal was to stabilize myocardium, and calcium gluconate reduces the excitability of cardiac cells, and hence it can be given slowly IV push. Dose is 0.5 ml per kg IV, diluted in equal quantities of 10% dextrose over 2 to 4 minutes. We should remember to push it slowly, otherwise heart may stop in systole. एक electrolyte को ठीक करने गए और दूसरे में गड़बड़ हो गई. Then insulin can be given along with glucose, because if you give insulin unmonitored without glucose, there is risk of hypoglycemia. Then beta-adrenergic agonists are very useful. Beta-adrenergic agonists are very useful. It can be given by nebulization, and so it can be given concomitantly with other therapies. Sodium bicarbonate should be given only if metabolic acidosis is present. Then remove excess sodium from body by loop diuretics. As we have seen, sodium is excreted in distal convoluted tubule. And in severe cases where there is renal dysfunction or hyperkalemia is too high, more than 6.5 or more than 7, then we can go for dialysis. Hypokalemia, it is equally devastating. We have seen a lot of cases in our OPD practices, typical patient with diarrhea, loose stools, and paralytic ileus. We have diagnosed and treated, I think, almost all of us. Usually children are not symptomatic unless it falls below 2.5 milliequivalent per liter serum potassium. So again, symptoms may be present, and it is mostly a clinical diagnosis. Etiology also can be deferred with the help of history taking itself. Management, we have said, Am I audible?
Yes, yes, you are
Yeah,
audible.
You're audible.
Yes,
You
thank
could
you.
just run through the slides too. They're
Yes.
running short of.
Yes, I have told these oral Kesol and injectable Kesol. Physiologies of sodium is very important. I'll just touch it up. Sodium is a unique among electrolytes because water balance and not sodium balance usually determines its concentration. Major cation of ECF determines osmolality, maintains intravascular volume. Hypernatremia, as the picture shows, brain hemorrhage is a fatal and devastating complication of untreated hypernatremia and also overambitious treatment of the same. So it has to be taken with pinch of salt. Treatment has to be taken with that. These are categorization. Mild to moderate hypernatremia can be well managed with the help of oral rehydration solution. It is only in moderate to severe or most severe that we have to treat aggressively. We have to treat shock as priority with bolus 20 ml per kg of normal saline. And if the deficit persists, we may repeat it. Then we should add on maintenance plus the losses which are going to incur losses. And then these boluses have to be subtracted from this. Correction of hypernatremia should be slow. If we correct over ambitiously to balance the osmolality between ECF and ICF, water will move from ECF to ICF to the cell, especially brain cell, causing edema, seizures, comatose. It has to be done slowly. This maintenance, the speakers prior to me have explained at length, so I will not touch it. We have to, in moderate hyponatremia, we have to correct it over 48 hours, which is to be slowly. And if seizure occurs, then irrespective of hyper, we have to give 3% of sodium chloride in the dose of 4 ml per kg over 30 minutes to 60 minutes. Aim should, in hypernatremia due to sodium excess, is to remove excess sodium. This is oral junk food in teenagers. This has been seen. So aim is to reduce sodium intake, and for other etiologies, dialysis and treatment of the cause. Hyponatremia is equally devastating. Similar things can happen. It is very tricky. Hyponatremia is very tricky. Kyuki it can happen. It is because of changed ratio of water to sodium. Ratio is
Overshooting time.
okay. Thank you so much.
Yeah, thank you, Dr. Madhu. It was a good presentation. And though this topic is very vast and you tried to finish it in 10 minutes, congratulations for that. 2-3 things I want to highlight only. Number one is that you have to maintain a volume. So initial fluid, again, as Dr. Ramakant sir said, should be NS and NS in any of these conditions. Secondly, mostly hyponatremia is because of the fluid overload or SIDH. Many sick children will retain fluids, and that is the leading cause of hyponatremia in children. Do not overtreat hyponatremia and just wait for that. I will put these children not on any IV fluid. I'll just wait and see how they behave and then treat. Unless it is a symptomatic hyponatremia where you correctly suggested that 3% NS, maybe 4 ml per kg will be required. Go slow is the message while treating hyponatremia also and while treating hypernatremia also. One should not treat it so vigorously that you get a decline of 6 milliequivalents in 12 hours. So that is how we have to go. Hypokalemia, I'm not at all worried about hypokalemia. Hypokalemia is never detrimental unless it is less below 1.5 or maybe 1 potassium, where you will get arrhythmias. Only then you have to be very vigorous. Otherwise, hypokalemia, body has that mechanism, the kidneys has that mechanism, the intestine has that mechanism to auto-regulate potassium. So I will not treat hypokalemia at all when the child is not sick or the levels are borderline low. I will rather, as you correctly suggested, will opt for oral potassium, because giving IV potassium is the last thing we want in a sick child, causing a lot of problems. Maintenance is okay. or maybe that more than that. Second is when you treat about hypernatremia, we see a lot of babies of hypernatremia and hypernatremic dehydration, especially in summer days in rural areas. We know all the causes of that. Here also the right choice will be 0.9 DNS. And books have mentioned 0.45 DNS, but I will stick to 0.9 DNS. And that has to be given over 1.5 times to 2 times, maybe in 24 to 48 hours. That should be the role. Because if you give 0.45 DNS here, again, it will be hypotonic and will lead to a lot of problems and will lead to seizures and problems. So 0.9 DNS has to come up unless you see that the maybe it is very borderline hypernatremia in that case. And again, in the hypernatremia, if the sodium is more than 195, 200, the child is throwing seizures, again give 3% NS. Even if it is high sodium, because we are going to treat cerebral edema, not we are going to treat for sodium. And it has to be very gradual. It has to be gradual. The homeostasis has to be maintained between ECF and ICF, and it has to be a gradual treatment of hypernatremia. I have seen reports of 185 and secondary report of 150. It is not done. It is not at all done. So it has to be a slow correction of hypernatremia as well as hyponatremia. Congratulations. Well done. Thank you.
Mandar, may I have 1 or 2 comments?
Yes, sir. Yes, sir. Sure, sir.
Yeah, so most important, as you have said, hypernatremia never to be corrected within 72 hours.
Yes.
It should be well beyond 72 hours to prevent problems. Secondly, in hyperkalemia, always check with your ECG and T waves. Are there really it is hyperkalemia or it is a erroneous lab representation? And that is very important. And as it has been taught in our pulse, whether it is a wide complex and narrow complex. So all wide complex QRSs, even in hypokalemia or hyperkalemia, are very dangerous. It has to be treated really aggressively as an emergency. And newer drugs, even now like Partimor or sodium zirconium cyclosilicate, they are available as Lokelma. This can be definitely, since it is available as oral preparations, it can be definitely used in emergency management of hyperkalemia, which are not responding to whatever conventional measures which have been given and can be given continued as oral therapy.
Absolutely.
Thank you. Wonderful presentation.
Thank you,
Very
sir.
nice slides. Both
Thank
of you, Sandeep and Madhu. Wonderful. All the slides were good, even of Nilesh, but these were very attractive. Thank you.
Thank you, sir.
Thank you, sir. Thank you, Dr. Ramakant sir. Thank you, Mandar sir, for these.
Kore sir wants to comment something. Kore sir.
Yes,
Yeah, Kore sir.
as we are medical professionals, we are bad in maths. Okay. And there is an app by Dr. Satish Pujari, RxPED, which gives all. You have to enter his age less than 1 year, more than 1 year. You have to enter his weight, his sodium, and he will give beautifully how to go ahead. It is freely available, so you can use it, and it is most appropriate. I have used it many times, and we cannot jungle in between the maths and all this as the patient is very serious in a PICU. So take a help of app. Mobiles are there everywhere now, and they can be used very efficiently to treat this. In hyperkalemia emergency, salbutamol has to be used, then calcium gluconate, and then if required, insulin and glucose drip, if not corrected with these two. Because salbutamol can be given immediately. If there is a hyperkalemia, you start with salbutamol and give calcium gluconate. Okay, thank you.
Sir, thank you for this very important session. Moving on next, I welcome Dr. Nitin Rawat, sir is from IIT Amravati Hospital. Am I audible?
Yes. Should I start?
Anand Hospital, Amravati. Yes, sir. May please proceed the topic: acute gastroenteritis management in SAM and MAM, role of antibiotics. Over, sir.
Yeah. Is slides visible, madam?
Yes, sir.
Yeah,
Yes,
they are
yes,
wonderful.
Nitin.
Yeah, okay.
Very
Okay.
vis-
A
good
very
visual
good evening to all the
and you are
respected,
learning it.
very good evening to respected seniors and my dear friends from IAP. Myself, Dr. Nitin Raut, presenting today AG management in severe acute malnutrition child, and also we will touch to the role of antibiotics in these children. So let me start. Actually, this is totally a different child when we treat diarrhea in a severe acute malnutrition. The whom do we call severe acute malnutrition is weight for height less than 3 standard deviation, MUSC less than 11.5, or visible wasting or bilateral pitting edema. Definitely rehabilitation is required for this child, and management of acute gastroenteritis is usually different. Weight for height between 2 to 3 SD, it's moderate acute malnutrition, and MUSC between 11.5 to 12.5, it's moderate acute malnutrition. These child, they are usually stable, rehabilitation is usually not required. What we are going to focus is management of gastroenteritis in SAM children, especially. So what are the common causes of acute gastroenteritis? Because in SAM child, usually they keep on presenting with diarrhea only. Most of the time, it may be the osmotic diarrhea also. Coming to the causative infectious causes, what we have is E. coli. And in parasitic infections, the commoner are Giardia, Strongyloides, Cryptosporidium, and Entamoeba histolytica. Now, going towards the signs of dehydration in SAM child, definitely the classical signs of dehydrations, what we have discussed till now in normal children, they are unreliable in the SAM child actually. There needs to be definite history of significant recent fluid loss, and with sudden onset within the past few hours or days. There should be a history of recent change in child's appearance, and mother must say that the eyes have changed to become sunken since the diarrhea started, because sometimes they usually have the sunken eyes. These kind of children, we can have the look. This is the child actually. We were blessed to treat that child. 1 year child with around 3.5 or 4 kg weight only. We can see the typical signs of dehydration, that skin folds or skin pinch going slowly like that. They cannot be very much reliable in the child, and eyes will be like that only. These are only. So this was the child presented with the signs of dehydration. So we should always remember the purpose of this slide is that these typical signs, they are not reliable. What we have discussed, that we need to see. Coming to the rehydration of these children, once we have, so what we have to do is, first we have to weigh the child, we have to mark the age of the liver and costal margin, we have to record the respiratory rate, pulse rate, and capillary refill time. And the malnourished child is managed preferably by the clinical signs of the improvement and clinical signs of the overhydrations. Definitely we have to monitor these kind of signs. What signs we have to check? Again, this respiratory rate, pulse rate, urine frequency, stool or vomit frequency, and signs of hydration that we have to see in this child while starting the management of dehydration and during the management also. Coming to the management of dehydration in severe acute malnourished child without shock, definitely the child may be presenting without shock, and with shock management is different. When the child is presenting without shock, we have to remember that we have to as much as avoid IV fluids, no IV fluids while correcting the dehydration in SAM child without shock. That is the dictum. And if the child had watery diarrhea or vomiting, assume dehydration, we have to give the ORS, that is Risomol, what we give the rehydration solution for the severely malnourished child. The amount to give is how we correct the dehydration is, for every 30 minutes for first 2 hours, we give the 5 ml per kg body weight. That suppose the child is of 5 kg weight, we'll give 25 ml every 30 minutes for first 2 hours. That will be the deficit corrections. And for the ongoing losses, what we are going to do is, for next 10 hours, we are going to calculate like 5 to 10 ml per kg, and we will start continuing this for next 10 hours, and we'll try to correct his dehydration. This protocol is given by the WHO, and this what is we are following for day-to-day treatment of dehydration in SAM child without shock. That we have to remember. These are the clear-cut guidelines. This is the Risomol preparation that is used than ORS in the SAM child actually, because they are usually the hypernatremic and hypokalemic. So what we do is, whatever we have this 1000 ml ORS packet, we dissolve in 1700 ml of the water. We add 40 grams sugar, and this electrolyte mineral solution is prepared actually in our NRCs also, Nutritional Rehabilitation Center. We usually prepare. If it is not available easily, our Portler solution also can be mixed 35 ml. So that will constitute the ORS for this severe malnourished child, that you should be used for the correction as given in the last slide. So this was for the child without shock. Coming to the management of SAM child with dehydration with shock. So when we are going to label the child as shock, if he has the cold hands, slow capillary refill, weak and fast pulse, definitely that SAM child is in the shock. Then we have to start the treatment accordingly, according to the guidelines, and we have to give this treatment of dehydration with shock in SAM child only if the child has signs of shock, is lethargic, and has lost consciousness. So first we have to establish that the child is in shock, then we'll follow this protocol for the shock child. We have to weigh the child or consider the weight. If it is not the child is very unconscious, we have to start with the oxygen. Make sure we have make the child warm. We have to insert IV line in this child. What I said is, in the SAM child without shock, no IV fluids. We have to stick to it. But in shock, we have to put an IV line. We have to send some emergency investigation. Can give 10% glucose, considering hypoglycemia is common in SAM children. 5 ml per kg. Again, the bolus, as discussed earlier in other presentations also, the bolus will be of 15 ml per kg over 1 hours of Ringer's lactate or over NS of the bolus. That bolus should be given. And again, we have to measure the pulse and breathing rate at the start and every 5 to 10 minutes. If there are signs of improvement of pulse rate and respiratory rate, that the previously the child was tachypneic, tachycardiac because of the shock, and now if the child is improving, there is improvement in the pulse rate and the respiratory rate, repeat same IV fluid bolus 15 ml kg over 1 hour more, and then we can again switch to the nasogastric or oral rehydration as we discussed in the previous slide. Oral management 10 ml per kg per hour. Purpose is as much as try to avoid IV fluids, and as much as early try to shift towards the oral management. And again, we can initiate feeding with the starter formula also. Alternate, we can give Risomal and this F75 actually. But suppose after giving that bolus, the child fails to improve after the first 15 ml per kg of the bolus, and the child RR also is increasing, pulse rate is not coming down, rather that it is increasing. So definitely we have to suspect that child might be in the septic shock also, and we have to start with the maintenance IV fluids. We have to review our antibiotic treatment. We may need to start the dopamine, and we have to, once the child is out of the shock, we can initiate the refeeding as soon as possible. So this was the protocol for severe acute malnourished child in shock. Coming to the role of antibiotic, osmotic diarrhea, it's very common after we start feeding to the SAM children. So there is no role of antibiotics. And infectious causes, what we discussed, which it should be treated based on the stool culture report. So in case of dysentery in the SAM child, ciprofloxacin is indicated in the guidelines as a 15 mg per kg in 2 divided doses per day for 3 to 5 days. If the child is 6 or already received a ciprofloxacin, we can give injection ceftriaxone in proper dose 100 mg per kg once a day, or in divided 2 doses for 5 days. And in case of these parasitic infections, we have to examine stool by microscopy, and if it is positive, metronidazole is given 7.5 mg per kg 8 hourly for 7 days. So this was regarding the antibiotics to be used in the SAM child in infectious causes. Coming to the management of persistent diarrhea, because they children usually present, they recover, they again present. Sometimes they may be presenting with the persistent diarrhea. So we can shift towards the low lactose diet, or sometimes lactose-free diet, what we prepare in our nutritional rehabilitation centers. And also we have to suspect and treat the associated infections also. So this was regarding dehydration in SAM child without shock, with shock, and about the antibiotics. And these are the child when we actually presented with SAM with dehydration and shock, and see we can, if we are stick to the guidelines after treating properly, how the child looks actually. So this was actually case we have treated in our NRC. So what the takeover message we are taking is, classical signs of dehydration, they are different in SAM than the normal child. Management of dehydration is different in SAM child and normal child, and there is limited role of antibiotics in management of AG in SAM child, and integrated only if infection is proven.
Thank you so much, sir, for being well in time. Over to you, Mahesh sir, for your expert comments.
Yeah, Dr. Nitin has done excellent job and he's working already in NRC. So he has a practical inputs from that. He has managed so many cases of SAM, and he rightly told us that it is very difficult from examination to differentiate between this where they are failure to thrive or they are looking SAM or they are dehydrated. You have to ask mother. So history is more important. And to the practitioners, I will give a hint that if a child comes to you, a severely SAM child comes to you, you'll say that this is a failure to thrive child. Okay. And then if he comes with dehydration and shock, you will try to give 20 ml per kg. And if you give 20 ml per kg of normal saline, the child will land into congestive cardiac failure and they will die. So you have to restrict bolus fluid. So what he has told us, so don't give bolus fluid in a SAM child because the SAM has affected all organs and it has already affected his heart also. So your boluses will not be tolerated by that SAM child. And that was the reason probably that FISH trial has shown that in Kenya, mortality was much more than the developed countries. So maybe they were dealing with these malnutrited children more. That is one point we have to take, because one of my colleagues said that he had a failure to thrive child and in shock, and she has given 20 ml per kg and child landed into congestive cardiac failure. So what was the cause? The cause is already there because SAM children have got more sodium in their body and less water. So that's why we have to adjust that Risomol. Why diluted ORS? Because they already have more sodium in them. And what is a deficit? Potassium is a deficit. If you don't give potassium, they will die. So you have to correct hypoglycemia. He has already told 5 ml of 10% dextrose you have to give, presuming that they are hypoglycemic. You have to understand that because they are more prone for hypoglycemia. They are more prone for hypokalemia and they are more prone for hypothermia. If you take these three together and treat, and they are already with sodium more. So don't rush to give sodium, NS, like other children. Otherwise, they will land into some problem. What you have to do, you have to go slowly. 15 ml per, where WHO says that 30 ml per kg within first hours. So you have to reduce the 15 ml. That is the WHO protocol again. If 15 ml per kg within 1 hour. If not responded, again one more 15 ml in a second hour can be given. And then shift to orally. Don't give maintenance fluid as in other children. Stop there. Only 2 boluses and stop there. That is your IV fluids. Okay. And give orally then that Risomol. And he has rightly said 5 ml per kg per hour gradually over a period. You have to correct it gradually. So his body will adjust and take care of hypoglycemia. Excellent presentation, Dr. Nitin. Thank you. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Moving on next, I call upon Dr. Harshal Bach. Sir is Assistant Professor, GMC Meerut, IIT Sangli District Branch. The topic is antibiotics and other pharmacological interventions in acute gastroenteritis. Over to you, sir. Dr. Harshal?
Yes. Am I visible and audible?
Yes.
Yeah. So good evening, everyone, and thank you, MahaIP, for giving me this opportunity to present on this platform. Since I'm the last speaker, I won't bore anymore, and I'll keep my lecture short. So the topic allotted to me is antibiotics and other pharmacological interventions in acute gastroenteritis. So most of the things have been covered in the previous presentations. So to begin with, the treatment of acute gastroenteritis comprises of rehydration, which is known as the mainstay for the management of gastroenteritis, rational use of antibiotics in indicated patients, which we'll be seeing in further slides. Probiotics are known as adjuvant in the management of gastroenteritis, and antidiarrheals, its role is known as an add-on in management of gastroenteritis. Whereas the most important part here is counseling of the parents, counseling of patients' relatives, that it is not just water flowing through a tap and it is not going to stop in 1 minute. It is going to take time, and there is need of patience for the same. And there is no need to pressurize the pediatrician to change the antibiotic, or there is no such need to change the doctor. That's the counseling advice that we'll have to give. So moving on with rational use of antibiotics. Antibiotics are not necessary for each and every case of diarrhea. So as rehydration is the key treatment for management of acute gastroenteritis, and most of the symptoms will generally resolve within few days. So probiotics and antidiarrheal agents are suggested to be adjuvant. Then what is the role of antibiotics? Antibiotics are recommended to shorten the duration, severity of symptoms, as well as they help to decrease its transmission. There are no clear indications for initiating the antimicrobial therapy, whereas antibiotics are frequently prescribed, and the overuse further helps in increasing the rates of antibiotic in resistant bacteria and further adverse events. So the risk factors indicating antibiotic therapy in acute gastroenteritis. These risk factors can be divided as host-related factors, clinical factors, and factors related to the setting where the patient is being admitted. So first, looking at the host-related factors, the absolute indication for starting antibiotics is in infants who are less than 6 months, specifically in neonates, and where there is severity of clinical presentation, that if a child presents with sepsis or shock, you have to start antibiotics. In malnourished children and in children who are having immune deficiency or chronic underlying disease, it is again strong evidence to start antibiotics. Setting related factors, if a child who is admitted in a daycare center or a hospital or a closed institute, it is an indication to start the child on antibiotics. So what are the clinical criteria to decide antibiotic treatment in acute gastroenteritis? So if a child presents to you with, say, otherwise healthy child presents to you with watery diarrhea, fever alone, child is playful, looks to be like viral etiology, there is no need of antibiotic here. So you can just rehydrate the child, use a probiotic, and child will be fine in a day or two. Whereas if the absolute indication here to start antibiotic is bloody diarrhea, if blood in stools, if a child is presenting with blood and mucus in stools, abdominal pain, and we are suspecting bacterial etiology, first the thing would be to send microbiological investigations and start the child on empirical antibiotic therapy. Whereas other absolute indications for starting antibiotic would be presentation with a toxic state, child having fever with increased inflammatory markers, malnourished child with immunodeficiency. So in all such patients, we are not going to wait. And in such patients, we are going to start empirical antibiotics after sending the investigations. And those antibiotics can be tailored as per the culture and sensitivity reports. So what do the recommendations say? So the WHO recommends that treat all the episodes of blood in stools with antibiotics, to start with empirical antibiotics first, and then to be tailored as per the culture sensitivity report. Fluoroquinolones are preferred. Why? Because they're effective against a wide variety of enteric infections, shigellosis, salmonellosis, and ciprofloxacin is the drug of choice, as it is available both in oral as well as IV formulation. So it is, as per WHO, the recommended drug here would be ciprofloxacin. For parenteral therapy of diarrhea, ceftriaxone, the third generation cephalosporin would be the drug of choice. Whereas in children with chronic conditions, oral metronidazole can be an alternative option. Whereas cotrimoxazole is still effective in malnourished and immunocompromised patients. Rifaximin may be considered as first-line treatment in children with colitis and in adolescents. So this slide is from Nelson Textbook of Pediatrics, as Raut sir has described, as per the sensitivity pattern, or as per what we are suspecting, which organism we are suspecting, or on the basis of bacterial etiology, we can think if it is Shigella which is causing the diarrhea. In that patients, we can start the patient on ciprofloxacin. In similar way, this is the drug of choice. So moving on with probiotics. So Indian Academy of Pediatrics consensus guideline for probiotic use in childhood diarrhea was published in 2022. What does it recommend? So it says Saccharomyces boulardii and Lactobacillus rhamnosus had significant efficacy in treatment of acute diarrhea. So these two are the probiotics of choice in case of acute diarrhea. Probiotic mixture helped in reducing the severity and length of the diarrhea, and the National Consultative Group strongly it avoids, or it says there is no recommendation for the use of probiotics in dysentery. Now coming on to the add-on part, that is antidiarrheals or the helpers, zinc supplementation. Now zinc has role in reducing the duration and severity of diarrhea. It potentially prevents a large proportion of cases from recurrence. So zinc will help in reducing the recurrence. Also, a study proved that there was a significant reduction in mortality as well as hospital admission in patients with diarrhea. Now, anti-motility drugs are to be used very cautiously. They have a restricted use in cases of patients who are having acute watery diarrhea, and in children above 8 years, they should be used. Their mechanism of action will be inhibiting intestinal peristalsis, and they have mild anti-secretory properties. They should be strictly avoided in bloody or suspected inflammatory diarrhea and not to be recommended in children less than 2 years. Anti-secretory agents like Resica-Dotril have effect by reducing the stool output and should always be not used in every diarrhea. Antiemetics like ondansetron helps by reducing the vomiting. It facilitates the oral rehydration and is suitable for the use in emergency department. So to end my presentation, there are two case scenarios. So if we see the first case scenario, an 11-month-old child presents to you with acute onset of vomiting, and followed by next day, the child develops 5 to 6 episodes of loose stools, watery, has mild fever, and vomiting stops on the very next day. On physical examination, the child is playful, signs of some dehydration are present, and there's anal excoriation present. So what it can be, is it viral, is it bacterial, or is it parasitic? So child is playful, multiple mucosal membrane involvement is present and started with vomiting, and then on the very next day, child is showing complaints of loose stool. So this is a common scenario, and probably this is acute viral infection. So how are we going to treat it? Rehydration, probiotics, and assurance would be the choice of drug that are going to be required in this case. Whereas this is the second case scenario, and this is the last slide, so I won't be taking much time. So here we have a 2-year-old child who presented with high fever, 3 to 4 episodes of loose stools. Now these loose stools are bloody mucoid, and the complaint is only for 1 day. And there are few episodes of vomiting, that is occasional vomiting. On physical examination, this is a sick child. Child is irritable and has no dehydration. So here, if we see child is having high-grade fever, 3 to 4 episodes of loose stools, that too bloody, blood and mucus present in the loose stools. So this somewhere shows that the etiology can be bacterial. And here there is absolute indication for starting the child on antibiotic after sending the microbiology investigation. So rehydration would be on the charts, first on the charts. Rehydration, antibiotics would be the management in this case. So my take-home message for the presentation would be rehydration is the key treatment. Treatment of diarrhea with probiotics should always be considered. Role of antibiotics in selected circumstances, considering clinical conditions, host-related factors, and setting where the patient is admitted, and counseling and reassurance of parents so that there won't be any change of antibiotics or change of doctor. So with this, I would end my presentation. Thank you.
Excellent presentation, Harshal. Though I will disagree with some of your points. Viral diarrhea would need ORS and zinc, and probiotic as adjuvant. This is how the company will market. What is adjuvant? It can be rarely used. And what is the evidence that probiotic reduces the diarrhea is by 6 hours prior to the not given stage. Say the
Right.
viral diarrhea reduces by 48 hours or 72 hours. In a probiotic given condition, it reduces 6 hours prior to that. That means that these are the terms used by the companies to promote
Yes,
their
sir.
products. Okay, so our aim should be a rational. What is rational is zinc and ORS in a viral diarrhea. Most of them are viral. Only blood, visible blood in a stool is the indication to give a antibiotic in a normal child. Like previous speaker shows that he has a SAM to deal with, Nitin. But SAM is an immunocompromised child. There you are justified giving antibiotics. He said that if the child doesn't improve severe dehydration, 2 doses, 15 ml per kg and 15 ml per kg of half DNS, because ringer lactate also contains much more sodium than the half DNS with or RL with dextrose, then you are justified giving that. It may be septic. Recommended is ampicillin plus gentamicin injectable at that point of time. And here will slightly differ because IAP recommends cefixime as a drug of choice because DCCI does not give permission to the fluoroquinolones to be used below 12 years. So we are slightly deviating from the WHO, but if you use fluoroquinolones for a shorter duration, doesn't harm anyway. It is not an off grade. But probiotics, I'm not with the probiotics. Probiotics are the adjuvant. Adjuvants means like Abhida Bachchan के साथ कोई तो और नाच रहा है बा वो कौन नाच रहा है मालूम नहीं, but we have to fill the show, that's why they are dancing there. Okay, so they are not the major part of that. Okay, so we will go with zinc and ORS in a viral diarrhea and antibiotic ciprofloxacin or cefixime in a bloody diarrhea. Visible blood is indication. You don't have to test it also. Visible blood with mucus, with high grade fever, tinnitus, must, all this present, then you are justified in giving a antibiotic, ciprofloxacin or cefixime. SAM is a different condition. SAM is an immunocompromised state. So you are justified giving more treatment to them. And as he said, culture stool is only in SAM condition because they are immunocompromised. You may get different organism, Cryptosporidium and Giardia, all sorts of conditions. And if they are recurrent, only you have to do stool culture or stool examination only justified. Nitin can add on that because he has a real-time experience from that NRC.
Yes, sir. Yes. Because we do get this kind of children's actually. Very common. Even the presentation is with diarrhea only. Whatever is the season, SAM child usually presents to health facility with diarrhea. Sometimes it may be related to feeding, osmotic, or most of the times infectious only. So we have to select, and they are usually working, sir. I have used metronidazole orally very nicely in this kind of children with dysentery and all that.
You may be dealing with Giardia for that.
Yeah,
Metronidazole work on Giardia.
Yes, sir.
Or amoebiasis.
Amoebiasis. Yes.
Okay.
Yeah. Dr. Kore, I want to add a thing or a comment on this thing.
Yeah.
That wonderful presentation by Nitin, that in all SAM, it has to be in late stage of shock, we will be giving IV fluid.
IV.
Not even in initial.
It's pulseless child,
Yes.
feeble pulse,
Yeah.
or gasping child, you are justified.
Yes.
So
A
giving
stable
RT
child,
feed, doing appetite test, giving F75 and ORS, these are the only thing even in SAM. So doing appetite test and F75 use along with ORS, even giving RT feed, ORS RT feed. That is very important in SAM. Wonderfully presented. Secondly, as Dr. Kore has rightly said, we have to prescribe all the drugs as per the prescription insert, PI, not even DCGI. Whatever the product insert says. If product insert says not to use below 18 years, we have to take consent for off-label use if we have pressed for that. So as Kore sir has said, it is always a cefixime. If patient is not responding, ceftriaxone. Azithromycin we have to keep for typhoid fever, which are drug-resistant typhoid fever. So we will not be using azithromycin. It will be cefixime, not responding, then ceftriaxone. Or patient is not tolerating orally or like that. For all practical purposes, for all age group, in pediatric, loperamide should not have any mention.
Absolutely. That I was
Not even beyond 8 years. No
8
mention of
years.
loperamide till 18 years also. So loperamide should not have any, it will not find place in mentioning like that. That is what I find is we should not recommend of this thing. And very aptly said by Dr. Kore that probiotic, it should be an individual choice rather than recommendation on this academic forum. And zinc has
they are the adjuvants only. So and what is probiotic? It is a good bug. Okay, and good bugs are there in plenty in India because we are not that very much sterile environment. So always there are everywhere good bugs are there. So you don't have to use it. They will automatically come to you. You don't have to go antibiotics to kill good bugs. Okay,
and
that is
even
one
in
more.
SAM patient, rather than stool culture, it is a very good stool examination for
Yes,
live this thing, cryptosporidium, that is again identified by good microscopy and staining. And here the nitazoxanide is the drug which dramatically stop the loose motion rather than even metronidazole or like that. So cryptosporidium in malnourished child SAM, we will use that is the only place probably for nitazoxanide in pediatric age group. So that we can be using for that SAM patients. So very nice presentation. Everybody had given
modified ZN sting should be done. Modified ZN sting should be done for cryptosporidium. And if you pick up, and nitazoxanide is a good drug, and they will beautifully respond. And they typically present with recurrent watery diarrhea, not responding. They are not like a viral diarrhea, which stops by 4 or 5 days or 7 days at least. They are continuing having watery diarrhea, and then you have to think of cryptosporidium in a malnourished child or in a sometimes healthy child also. You have to do but that modified ZN sting. If you get cryptosporia,
watery diarrhea going for weeks.
Weeks.
Yeah, with good appetite. You
Good
have
appetite,
to
yes,
suspect that
absolutely.
this is a cryptosporidium even in a healthy child. Even in non-immunocompromised child also, particularly below 2 years of age. So very nice presentations.
Yeah, thank you,
Over
Arshal.
to Kore sir. Yeah.
Thank you, Arshal and Nitin, for a wonderful presentation. You are both are good, and we really like your presentation.
Thank you.
Okay. Thank you. Thank you very much.
Thank you.
Very much thankful to our expert judges, Dr. Mandar Deshpande sir and Dr. Kore sir, as well as our president, Dr. Ramakant Patil sir, for their valuable inputs. Really, zinc and ORS work well in viral diarrhea, and role of cefixime and ciprofloxacin, especially in bloody diarrhea. There is one question in chat box by Dr. Shekhar Dabadkar sir. Please comment on ofloxacin and ornidazole combinations, or like cefixime or oflox. Dr. Kore sir, would you like to answer?
Yeah, I have never used this O2 combination. I said, the child came to me saying that he is on O2. Then I said that why he is on outside OPD? He must be in PICU. So then I read this is a different O2. Okay, then I came to know that it is ofloxacin and ornidazole combination. I never seen it before. So I gone through it. Should not be used. This is should be discouraged, and as Ramakant said, should be thrown in Arabian Sea or whatever Bengal Sea.
Okay, sir. Thank you.
So
Sir, my
what
another question
I
is-
want to comment here again. See, even less than 2% of diarrhea or dysentery in our current setup in immunocompetent children is amoebic or giardiasis. So even per se metronidazole use is also very limited. And you see all these quinolones and ornidazole and imidazole causes lot of vomiting.
Yes.
Why we people are using this? Even I don't dare to use even imidazole. Keep aside quinolones. So I have not used quinolone unless until I am pressed to wall. In cases of urinary tract infections, and patient doesn't want to, I cannot give parenteral therapy. There and there only I have used quinolones. Otherwise, quinolones are causing too much of a vomiting, and already these are the gastroenteritis. And as Dr. Dabadkar has rightly said, it is criminal to use this combination as far as academics goes.
It's
And
really
sec-
crime. We should sue these pharma industry, because so many general practitioners, not only pediatricians, are using. Today I have seen one premature baby received ofloxacin and cefixime combination. So it's really very bad. And you should mention in all seminars of gastroenteritis that O2 should not be used. Should not.
yeah.
Kore-sir was
And
saying something.
My job was to remove all the bottles from that gastroenteritis child, and they become all right. They were vomiting just because of they were taking O2.
Yes.
Okay. It is
Thank you.
horrible, and smell is horrible, taste is horrible. So you should not prescribe that.
Thank you, sir. And my last question to Dr. Mandar, sir. Any role of furazolidine used especially in PHCs? Would you like to comment on that? Can we use furazolidine especially in not in viral diarrhea, but in antibiotic? If we think that we have to give antibiotic, can we give furazolidine?
No, absolutely no. I have never used this drug, and I'm not aware of this drug. So I have never used this drug, and I think it should not be used. As correctly mentioned, it has to be cefixime if it is a bloody diarrhea with classical signs of bacillary dysentery, proved on stool routine examination. That's it.
You may
If the child is too sick and is shocked and you are suspecting a septic shock, better to take the cultures and give ceftriaxone. Yes, sir.
I think it is indicated in giardiasis, pyroxone. You can correct me.
Furazolidine was the drug of 70s, 80s, and 90s.
Yes, sir. Yes, sir.
It was
But
not.
still it is there in PS.
Yeah,
Yes, sir.
PSCs
Still
is
it is
never there.
Never used and never seen that
Even
drug.
in 80s and 90s, it was being tried for the enteric fever also.
Yes.
But it is a bacteriostatic drug. So furazolidine is not to be used. And we know less than 10% of gastroenteritis need antibiotic.
Yes.
And as Dr.
Yes, sir.
Kore has said, it has to be fever, pain in abdomen, blood and mucus, and tenesmus.
All this.
Yeah. So then and then you are clinically are justified in giving antibiotic. There again it is cefixime. If not ceftriaxone, we shouldn't be going beyond this. As
If
it
it
is
is a
being
toxic child,
taught to us by many our stalwarts, we need to have only 4 or 5 antibiotics in our OPD practice.
if it is a
Not more than
toxic child, blood and mucus, tenesmus, give treatment as a bacillary dysentery. If it's not toxic and age is like 7-8 years, blood and mucus, you have to do stool examination. It may not be bacillary dysentery, it may be IBD, inflammatory bowel disease, a first episode of IBD. Okay, you have to be very careful for that, because toxicity, tenesmus, blood and mucus, cramps, all these things fit into that bacillary dysentery. Then only you are justified in giving antibiotic. If only blood and mucus is there and child is not that toxic, then the differential diagnosis widens. It may be amoebiasis. You have to do stool examination for that.
And sir, even in infants, if you see blood in stools after gastroenteritis or with the episode of gastroenteritis, and you see that the abdomen is having pain and there is a tenesmus, maybe some lump, always do ultrasound. We have missed many interceptions treating them as bacillary dysentery.
Yes. Yes.
But nowadays we have to be more cautious and we repeat sonography after 6 to 8 hours, and many of these interceptions are gone away.
Absolutely.
So we have to follow them up clinically, whether child is improving or not. If child has improved passing motion, don't go with that single report of interception sonography.
Absolutely.
We will not be putting them for hydrostatic reduction or even for surgery. Have a repeat sonography. And this is a common occurrence nowadays for last 2 years.
Absolutely, sir. Most of them are transient. Most of them are transient, and 80% requires only conservative treatment. Just wait.
Jejuno-ileal and ilio-ileal are transient one.
Yes.
Ileocolic will require only treatment. You have to remember this. Jejuno-ileal will be transient one. Ilio-ileal will be transient one. You have to observe them. And ileocolic, most of the time, it can be sometimes self-reducing, but ileocolic will require some surgical treatment or hydrostatic treatment.
If the ileocecal wall has become a part of intussusception,
That's
it
why
is
it is
less
called
likely to get,
ileocholic.
it is less likely to get reverted
Re-
on its
on
own or even by
spontaneous
hydrostatic,
reduction.
or
Yeah.
even by hydrostatic reduction.
All others are transient.
Okay, thankful to all respected dignitaries. Moving towards vote of thanks. I'm as a chairperson, I am really very thankful to President Maharashtra IP Dr. Ramakant Patil sir and Secretary General Dr. Amol Pawar sir, because of their guidance, we are able to conduct this session today. We are thankful to our MMC observer Dr. Sachin Gaikwad sir. And most thankful to our experts for their extreme guidance, Dr. Mandar Deshpande sir and Dr. Mahesh Kore sir. As well as I am very thankful to speaker Dr. Nilesh Shinde, Dr. Sandeep Gaikwad, Dr. Harshal Wagh, Dr. Madhur Karwa, and Dr. Nitin Raut for their excellent and wonderful presentation. Really, they presented their topics so well that we are just brush up our all knowledge today, and definitely we are going to implement it. I am very thankful for the all the respected Central IP dignitaries and Maharashtra IP dignitaries who attended this session, as well as I am thankful for all the delegates. I am thankful to to digital team, Pallavi madam, for this session. So thank you very much.
Thank you.
Our next session will be in August, 15th of August is coming, our next session. Thank you very much.
Bye.
Good night all.
Thank you very much. Thank you.